welcome back, and thank you for joining us for the HPL seminar today. Today, it is my pleasure to introduce Dr. Emily Matijevich, who is a Senior Director of Clinical and Applied Research at Orbix Medical Technologies, and also serves as an adjunct professor here in kinesiology at the University of Calgary. Emily and I go back a bit, but she has a lot prepared in her presentation to tell us about her background. So I've crossed everything out I had prepared for the introduction, and I will let her do that. But before I let her do that, I do want to share the fun fact that she wrote in her introduction, and said that she teaches yoga classes in her free time and lives on a farm with her partner, along with goats, chickens, cats, and dogs. And I think it would be great if she hosted a goat, chicken, cat, and puppy yoga session for all of us here at the HPL at her farm. Just hint, something to think about. But today she will be presenting her research on a brief history of remote patient pedal monitoring. So please join me in welcoming Dr. Emily Matijevich.
Awesome. Thanks so much, Ashna, for coordinating me to join today. Thank you for you all for being here and giving me the opportunity to share a bit about our research at Orbix and some of the collaborations we've had with the University of Calgary. Quick disclaimer, I am an employee of Orbix Medical Technologies, and some of the exploratory research I'll talk about today that's underway at Orbix and its described use cases have not been reviewed or cleared by the FDA or Health Canada. Who am I? Quick background, I grew up in Chicagoland. From there, I did my bachelor's in bioengineering at the University of Illinois. That's when I first had the opportunity to get involved in undergraduate research. I joined Assistive Technology Lab and got to work on powered ankle foot orthoses to support users with Parkinson's and multiple sclerosis. That really gave me a passion for research, and I moved down to Nashville to do my graduate work at Vanderbilt University with Dr. Carl Zellick. My dissertation focused on using wearable sensing technologies to monitor overuse injury risk in runners at risk of bone stress injuries, and in individuals that perform repetitive manual lifting at their job and are at risk of low back injuries. And it was actually during my time at Vanderbilt that I first got connected with a few folks at the HPL. I had attended an ISB in Brisbane, and I had given a presentation, and Benno was in the audience, and we got to chat after my presentation. That was the first time I met Benno. And I also have a memory of my advisor, Carl, and I were sitting in his office. We were on a Skype call with Brent, and this was pre-COVID, so Skype calls were like these really novel things that you set up in a video call. And Brent gave us some schooling on bone stress injuries and how you model a bone damage. So from there, like many of us who do our graduate work and don't know what we want to do with our lives, you go on to do a postdoc while you continue to figure that out. So I was really fortunate that Benno was willing to host me for a postdoc here in the Faculty of Kinesiology. During that time, I had the opportunity to work on many industry collaborations, working with footwear brands on advanced footwear technologies, helping CCM with the fit and function of their skate design, a little work with Dr. Scholes to try to understand the mechanisms of pain reduction with orthotics. So really enjoyed my experience then, and you all live here, you all know, Calgary's a fly trap. Once you're here, you don't want to leave. And during my time at the HPL, I had some opportunities to work with Orbix Medical Technologies, and I was really inspired by their mission to use wearable sensing to extend health span in individuals with diabetes. And it was great timing that they were looking to build out their biomechanics and research expertise. So I joined the company full-time in 2023, and I've been there ever since. And last year, I was appointed adjunct assistant professor in the department. Okay, so at Orbix, what problem are we trying to solve? About 40 million Americans live with diabetes. That number is about 5 million in Canada, or 15% of the population. Diabetes is a multifactorial disease. It affects almost every system of your body. But the aspect of diabetes that we're focused on is lower limb care. About 1 in 4 individuals with diabetes develop a diabetic foot ulcer or wound on their foot during their lifetime. And individuals with diabetes have reduced healing capacity due to their compromised immune system and reduced circulation in their feet. So these diabetic foot wounds are very difficult to heal. And about half of them become infected. And in the worst case scenarios, these lead to partial amputation of the foot or of the lower limb. In the US, annually, there's about 150K amputations to the lower limb due to diabetes-related complications each year. So While this certainly has a really significant impact on patients' quality of life, it's also very expensive. So managing foot wounds, infections, hospitalizations, amputations is very burdensome on the healthcare system. And it's estimated about $1 in every $3 spent on diabetes care goes to lower limb care. So this is about not only health outcomes, but also healthcare resource utilization. So we're really focused on this space of diabetic foot ulcers and how we can prevent diabetic foot ulcers before you go downstream to this cascade of more severe complications that are both costly and strong impacts on quality of life. So a quick recap of what a diabetic foot ulcer is in case you're not familiar. Patients with diabetes often suffer from sensory and motor neuropathy. This causes decrease in pain and pressure sensation in your feet. And it also increases the likelihood that you have foot deformities or gait abnormalities. And this combination of risk factors puts the foot at risk of experiencing abnormal pressures during your daily living. And while there's certainly risk due to repetitive pressures and stresses on the feet, you think your cyclic forces while walking, a bigger risk factor is those low sustained pressures that the foot experiences without offloading. So this mechanism is very similar to a bed sore or another pressure wound. Prolonged pressures on the skin result in impaired blood flow, and that can eventually lead to tissue damage. So just to kind of show you the pathway of a typical diabetic foot ulcer development, the tissue damage often begins due to those abnormal pressures. It'll result in a superficial callus. Without treatment, ongoing inflammation and pressure can cause more tissue breakdown and maybe hemorrhage beneath the skin. And eventually, in a worst case scenario, this leads to a full thickness diabetic foot ulcer. So today, I'm hoping to share a little bit about the evidence of one diabetic foot ulcer risk reduction strategy that's focused on temperature monitoring of the foot. Fast forward to the present today, how we're using digital enabled solutions and wearable technologies to support risk reduction of diabetic foot ulcers and build on this history of temperature monitoring in the diabetic foot. And I'll look a little bit towards the future and where we're excited to extend to new opportunities in diabetic foot care and beyond. So start with the past. This is a bit of an unexpected beginning. We're going to start with leprosy disease, even though we're talking about diabetic foot ulcers here. So the story begins with Dr. Paul Brand, who was born in India to English Christian missionary parents. And his parents ran a small medical clinic where they were focused on supporting and welcoming all patients to their clinic. And this really inspired Paul to go off and get his medical degree. After he finished his medical studies in London, he moved back to India, and he was invited by Dr. Robert Cochrane, who was a renowned leprologist, a doctor of leprosy. And he was given the challenge by Dr. Cochrane to try to explore and understand why individuals with leprosy developed such horrific lesions and deformities on their hands and feet. There's quite a bit of stigma surrounding leprosy, and the traditional view of how these hand and foot wounds developed was that they were a result of some spontaneous infection in the body or the hands and the feet, and that leprosy patients are burdened with this horrible non-healing flesh. But this mechanism didn't really sit right with Dr. Brand, and he suspected that the lesions were actually related to nerve damage, and a loss of pain sensation in the body made individuals more susceptible to injury, and that was actually the mechanism of lesion development in these patients. So to start off, he looked at 25 teenagers. These were individuals with leprosy, and he observed them as kind of this early research study subject. So after observing these individuals with leprosy, what did he find? A few key observations. When he examined the tools that they were working with, he noticed that there were blood stains on the trade tools at the same locations that they were developing wounds on their hands. So this made him start to believe these weren't spontaneous lesions that were just developing anywhere in the body. It was somehow related to the parts of the body that were experiencing stress on the tissue and pressure. He observed these individuals while they were sleeping. I find this quite horrifying. And he noticed that rats would nibble on their insensate hands and feet while sleeping. You can imagine if you had a rat nibbling on you, we have intact sensation. We would swat that animal away. But without that sensation, the animals were able to do damage to their hands and feet. There's a story that at the time, the solution to this was they introduced cats into the sleeping quarters. So hopefully that helped. And he also observed them while they were walking. And something that surprised him with that was that the patients were limping on their sensitive foot, but not their insensitive foot. Limping is often our response to avoid pain. So you would normally think you would be limping on that foot that has pain, but when you have no sensation, you don't have that response. So these observations together started to build this story about how there's this significance of neuropathy and a loss of sensation that was contributing to these wounds in individuals with leprosy. So Dr. Brand wanted to continue this research. So from the 60s to the 80s, he moved to Carville, Louisiana, to the National Hansen's disease. Hansen's disease is another name for leprosy. And at the time, this was the only US leprosy hospital. So if you wanted to do leprosy research, this was the place to be. And during his time there, he teamed up with Harry Bergfeldt, who was a physical therapist and athlete. And they wanted to better understand if there was a way to test and objectively assess how pressure on the body would lead to inflammation. So they had a volunteer athlete participate in this study, and they wanted to take infrared thermograms of their feet to start to understand how applied pressure contributed to warmth of the skin or inflammation. So at baseline, before this athlete started running, you can see that the back part of their foot is warm, and that the toes at the top of the foot are actually too cool. The distal parts of our body are cooler. They didn't even register on this thermogram. The study method said, I don't know why they didn't have any outdoor space. They had this athlete run through the cement corridors of the leprosy hospital. So that doesn't sound like a fun experiment, but they took these incremental thermograms at 2 miles, and they began to see that the feet began to warm up, and they were starting to see some asymmetry in the feet. And again, a thermogram at 4 miles and 8 miles. And this began to show them that when you apply pressure to the feet, that causes temperature increase of the foot. It's an indicator of tissue inflammation and warmth. The runner actually didn't even know that they were limping, but the researchers were noticed that they had an asymmetric gait, and that was corroborated by their left foot here registering warmer temperatures than their right. So what came next? To be a little more systematic about this, they turned to a more controlled lab-based experiment. They worked with anesthetized rat limbs, and they developed this repetitive pressure machine, which I feel like looks like a archaic version of some of the more fancy machines that probably exist in this building that apply controlled stresses and strains. But the purpose of this machine was to continuously hit the foot of a rat with a pressure or a stress that was similar to a rat running. And then they wanted to use thermograms to evaluate how those repetitive pressures contributed to inflammation of the limb. What did they find? If we're looking at the pre-stress thermogram here, these are the hind limbs, the rear feet of the rat. Both the left and right limb look quite symmetric, normal histology. And after applying 10,000 repetitions of pressure, cycles of pressure over 2 days, you can see that the foot they applied to is beginning to warm up, show signs of inflammation, and the further exam showed these signs of edema and inflammation. So they were really starting to build this story about how pressures on the body contribute to tissue inflammation in the surrounding tissues. So while this was all happening at the Hansen's disease or leprosy disease hospital, much of Dr. Brand's legacy was actually late in his life, how he translated these learnings to our knowledge about diabetic foot care and diabetic neuropathy. So he concluded that many of the observations in leprosy are equally relevant to the management of the insensitive lower foot and diabetes when you have diabetes and that loss of sensation due to nerve damage. I think this is fascinating. 1969, even in 1969, he was proposing developing pressure-sensitive devices to alert patients when pressure under their feet during walking was too high. And in combination with Harry Bergfeldt, they proposed thermography could be used to detect an area of the skin that was at risk of breakdown. So much of this was happening in a research setting, but how would this actually translate into clinical practice? This is one of the first clinical cases using thermography in an individual with leprosy that was proposed. So in a clinical practice setting, there's many ways you can measure temperature, palpation, like how you feel fever on your forehead. You can use things like thermistors, or you can use this infrared thermography, which takes a photo of the foot and shows you on some sort of heat map scale areas of the foot that are warmer and cooler. So this was a case study that was published in about 1980. This is a 50-year-old man with Hansen's disease who had partial loss of sensation in his feet. He was very active and he would often go jogging. And he reported that he would feel mild discomfort in his right foot, but it was not because of his reduced sensation. It was not significantly impacting his quality of life. So it wasn't until 6 months later that he was in the hospital for a routine doctor's visit. And the doctor captured these thermograms and saw this large asymmetry. The right foot was about 5 degrees Celsius warmer than the left. And it turned out he had 5 metatarsal bone fractures in his right foot. Treatment at the time was they prescribed him some modified shoes and orthotics that were intended to offload that limb. And after 2 months, brought him back in for a repeat thermogram, and the left and right feet are much more symmetric. And it was also highlighted at the time that these thermograms were a really great supplemental education tool to motivate the patient to see the problem and see the progress. So this was a case with leprosy disease. To my knowledge, the first known publication of using temperature monitoring in the diabetic foot came several years later. This was published in 1986. Title of this paper, in diabetes care, use of liquid crystal thermography in the evaluation of the diabetic foot. Liquid crystal thermography is kind of like sorcery to me, but what's happening here is that rectangle in the left image. There's a bladder within that rectangle that contains cholesterol molecules that are sensitive to temperature, such that the wavelength of light that they emit is proportional to the temperature they're perceiving. So you have this bladder with your cholesterol molecules, but that doesn't actually capture an image. So they kind of jigged up this Polaroid camera to then take an image of that elastic bladder containing the molecules to capture these thermograms of the feet. So in this study, this was 65 males from the U.S. Veterans Affairs Medical Center in San Francisco. And they evaluated some with diabetes, some without, and some with active foot ulceration to start to qualitatively understand what these temperature or thermographic patterns were in individuals with diabetes. So this is a case they're showing here with an active foot ulcer. You can see that area of the foot is warmer and has that characteristic circular pattern of a foot ulcer. So I don't have this in my home, right? This is constrained to a clinic setting. And when you take these sort of thermographics measurements in a clinic setting, this is great, but it really focuses on capturing the symptoms that exist in that moment. It doesn't help you proactively identify any changes in the foot physiology or provide proactive care. So the next step was here from once you've been measuring things in the clinic, how do you take it to a home monitoring setting? The first study that was published looking at using home temperature monitoring of the foot to prevent ulceration, this was published in 2004. And the authors proposed giving the participants these handheld thermometers, similar how you take the temperature on your forehead. And the goal of this was to monitor measures on the sole of the foot to warn patients when there is upcoming inflammation or ulceration of the foot. And when you're using handheld thermography of the foot, rather than using an absolute temperature threshold for what's considered temperature of concern, they were looking at using the opposite extremity as the control. So our feet are very much influenced by our environment, whether it's winter or summer, whether you got cold feet or you're active or you're not active, can cause a lot of fluctuations in your peripheral temperature. So rather than setting an absolute temperature threshold, they were looking at anytime there was a deviation in one limb compared to the other, using your other limb as a self-control. So this is some data that was included in this study. Here, the x-axis is duration in days across time, and the y-axis is the left-right temperature asymmetry. Again, we're comparing the 2 feet to each other to kind of account for those environmental confounds. And some prior work on sensitivity and specificity analyses identified this 4 degrees Fahrenheit or 2.2 degrees Celsius as a clinically relevant threshold, that anytime your 2 feet were had an asymmetry that exceeded that threshold, that was considered cause for concern. So you can see here, this individual that was monitoring their foot, at the time that they consistently were outside that threshold, a wound did develop in that location. Following this study, there were several additional clinical research explorations using this type of home temperature monitoring protocol for helping to prevent diabetic foot ulceration. Typically, the action when a user would measure a temperature trend of concern was they were either guided to reduce their ambulatory activity until the inflammation subsided or call their nurse or healthcare provider to get support. This converged on a meta-analysis that was published in 2021. It summarized 5 temperature monitoring randomized control trials that were using temperature monitoring of the diabetic foot. And the conclusion of this study was that participants allocated to the at-home foot temperature monitoring had a reduced risk of developing a diabetic foot ulcer. So this is really exciting, and kind of a really great update was there's this international working group on the diabetic foot. It's an international group that puts out guidelines on various aspects of diabetes care. About every other year, they publish guidelines specifically on the prevention of foot ulcers in persons with diabetes. And their 2021 update, which included 16 guidelines, one of those guidelines was to coach a person with diabetes to self-monitor foot skin temperatures once a day to identify early signs of foot inflammation and help prevent a first or recurrent plantar foot ulcer. So just to recap the history we're talking about here, the story had kind of unexpected beginnings, leprosy beginnings, and Dr. Paul Brand's work, we owe a lot to him and his persistence in challenging those existing beliefs about how foot wounds and pressure ulcers develop. And he really reshaped our understanding of neuropathy and the development of wound development. And then it was exciting to see, following his learnings, there were decades of research looking at using temperature monitoring both in a clinic and at-home setting to support the monitoring of the diabetic foot. And then now currently it's included in these international guidelines. So changes in clinical practice certainly don't happen overnight. I think this is like 80 years to make this one update to clinical practice, but I think it's really exciting to see the history and what we've learned about using remote temperature monitoring of the foot to support reducing the risk of diabetic foot ulcers. Okay, so where are we at today? So all of those studies that I was talking about were using handheld thermography to measure the temperature of the foot. So this literally means that an individual with diabetes takes a thermometer and measures temperatures on the bottom of each foot and compares those. There's a few caveats there. You have to remember to measure the temperatures of your feet. You have to be able to reach the bottom of your foot or have someone at home to help you take those temperatures. And then at the time of these studies, there weren't these fancy apps that like connect the thermometer to your phone. So you got to write the temperatures down and monitor how things change over time. So you can imagine there were adherence and compliance challenges with this sort of workflow. And moreover, diabetes, like we talked about, it's a multi-system disease. It's very complex to manage. So these patients already have a lot going on. So there were certainly barriers to adherence and enabling these patients to leverage this tool. So to address these adherence challenges and deliver kind of a holistic circle of care, digital enabled solutions have been introduced to do 2 key things. First, they simplify the capture of the measurements rather than having to use a thermometer to take these measurements of the foot. Can you have a smart way to capture those measurements? And then the second thing they do is really data management. They do something with that data and organize and move the data around in a way that's meaningful for supporting the patient. So this is just a highlight of a few products that are available to patients today. Photometrics and Blue Drop are both these sort of smart mats, or it looks like a bathroom scale. It's something you keep in your home and you step on it once per day. Photometric smart mat, it grabs temperatures of your feet, and the Blue Drop, it grabs temperatures and it also takes photos at the bottom of your feet. Siren Care Smart Socks, they're socks intended for individuals with diabetes to wear during their activities of daily living, and they're embedded with temperature sensors. I hear they're washable, but it still kind of grosses me out. And then I work for Orpix, and the Orpix sensory insoles are custom orthotics embedded with sensing technology, again, intended for use during daily wear. So I'll share a little bit about what the Orpix program is to set the stage, and then I'll talk about the research we've had underway with the sensing technology. So who's eligible? Who is this Orpix sensory insole program for? We primarily are prescribed to patients in the US, and we have some sales here in Alberta through First Nations programs. This is for individuals at high risk of diabetic foot ulcer. Typically that means someone with diabetic neuropathy, reduced sensation in their feet, a history of previous foot ulcer or amputation or Charcot. It's not intended for individuals with active foot wounds. This is really a prevention system. So it's not intended to manage an active foot wound. And then there are some behavioral considerations as well. You have to be willing to participate in remote monitoring and you're eager to make lifestyle changes. Program has several components. It starts with a sensorized insole. By the time you're at this stage of your diabetes, you're typically prescribed diabetic footwear and custom orthotics. So a custom orthotic means a podiatrist or an orthotist will take an impression of your foot or a 3D foot scan, such that the insole is contoured to the shape of your foot to help reduce the plantar pressures on your foot. And there are sometimes additional design considerations. The podiatrist will prescribe an offload or posting on the insole to help accommodate any foot deformities or worries about plantar pressure. So our production facility is in our office right here in Calgary and Inglewood. So we have a production team, I think of about 10 or 12 individuals that they receive the orders for that custom contour orthotic. And then they create the foam orthotic. Embedded in the middle is that sensing technology, which we'll talk about a little bit more. Like we talked about, managing diabetes is already really hard. So everything is about creating a really seamless and frictionless patient experience. So they don't have to do anything to get the data off the insole. Last year we launched this device called the Orpix Hub. It's something you plug in at your home and then you forget about it. So the data from the insole is transmitted over Bluetooth connection to the Orpix Hub. And then the hub has built-in cellular connection that sends the data to the cloud for back-end analytics and remote monitoring. So there's nothing the patient has to do here. The data is automatically pulled off the insole anytime they're in their home and their insoles are in range of the hub. Data goes to two different places. For those users that are interested in having real-time biofeedback, we have an app that they can put on their iOS or Android phone, and it provides real-time pressure offloading cues anytime that there's been pressure on their foot over a threshold for a sustained period of time. Not everyone wants another app. So if you don't want another app, we also provide remote patient monitoring. So we, Orpix, employ a team of credentialed healthcare nurses across the US and Canada that remotely monitor the patient's data according to where they are licensed to practice. To provide just a little more detail on the sensing technology, the top and the bottom of the sandwich are a bunch of foams. We have to follow certain guidelines to be compliant with what's considered a prescription diabetic orthotic. But the middle of the sandwich is the exciting part, the sensing technology. There's 5 temperature sensors that are located underneath bony prominences of the foot that are at high risk of ulceration. There's pressure sensors across the surface of the foot. The number of pressure sensors varies based on the insole size to ensure proper coverage. And then the electronics assembly kind of contains the brain of the insole as well as an inertial measurement unit for motion and activity tracking. So very natural question, does it work? Does it actually help prevent diabetic foot ulcers in patients? Our flagship study was this 2014 to 2016 randomized control trial. So this occurred before I was with the company. But it was a 58 patient RCT with 18-month follow-up. Half the participants were allocated to a control group that were receiving standard diabetic foot care, and the other half were receiving standard of care, in addition to real-time pressure offloading feedback from the Orpix sensory insole system. The study found 86% reduction in diabetic foot ulcers in those users that were adherent to using the pressure offloading system. Since then, we've built on that with some other case studies and observational studies, 13 peer-reviewed publications to date. There's also been some economic modeling work to demonstrate cost savings. But kind of the real exciting part is the tiny part. But our collaborator, Dr. Caitlin Hicks at Johns Hopkins University, she just received approval for NIH R01 for a randomized control trial that will be 400 participants for 12-month follow-up to evaluate both health outcomes and cost savings with the Orpix sensory insole system. We've made a lot of updates to the product since that 2014 to 2016 study. And also in the land of RCTs, 58 patients is sometimes not the most compelling evidence in certain lines. So we're really excited to be using the most current version of the technology as well as a larger patient cohort. It'll be a multi-site study. We're hoping for about 5 sites across the US. And it'll kick off this spring. So we're all really excited about this trial to build on our evidence base. I'll go through next a few key data themes or data differentiators of the sensory insole program that we've spent a lot of time on. So one is continuous monitoring. So what does continuous monitoring really mean? And I think the best metaphor is to think about glucose monitoring. We know that many physiological signals can fluctuate throughout the day. And there's already been this transition from discrete measurements to continuous monitoring. So you can imagine if you're someone with diabetes and you've been part of this transition from discrete finger prick glucose tests to continuous all day monitoring, that really unlocks a lot of insights for both patient and provider about how their nutrition, their activity, and their habits contribute to those fluctuations in their glucose readings, and how they can be more proactive in managing their glycemic control. And we really think there's a similar paradigm with a shift from daily temperature monitoring, those early studies that did handheld once or twice daily temperature monitoring, to continuous underfoot monitoring with sensorized insoles or other types of digital enabled sensing technologies. So to kind of motivate the value of continuous monitoring, I'll show a few examples of temperature data from the Orpix sensory insole. Here, the x-axis is 24-hour hours, and the y-axis is measured temperature. The two lines are corresponding to temperature readings on the left and right foot. For this user, the temperature measurements fluctuate throughout the day, but the difference between the left and right stays quite consistent. So if you're focused on identifying temperature asymmetries, it wouldn't really matter if you took a measurement in the morning, afternoon, or evening, the story would be the same. But this is not how all the diabetic foot physiology looks. This is another example. Again, x-axis is 24 hours, a different user. You can see for this user, the asymmetry is smaller in the beginning of the day, and it grows throughout the day. So depending at the time you would take a snapshot or a discrete measurement, you might get a very different story about their foot physiology trends. So Miriam Hajizadeh, who's a biomechanical data scientist at Orpix, she did a study on over 1,000 data days of Orpix users, and she found the vast majority, over 82% of data days, are time varying. And this really motivated the value of continuous monitoring and capturing these repeated measurements to have more confidence in these foot physiology signals. We also have been lucky at Orpix. We've hosted several of the WeTrack work experience students. Ray and Shaima both joined us for their work experience, and they leveraged their expertise in algorithm development to develop some classification algorithms to try to identify these different patterns we were seeing in these left and right foot temperature asymmetries. Sometimes you see the temperature asymmetry grows throughout the day, or it gets smaller. And that was really exciting. They were able to help us try to systematically identify these different patterns. But no matter how good you are at classifying whether the signal looks like this or that, it only really matters if you know kind of how your clinical action would differentiate with these different types of signals. And that's certainly something we're still learning about, but we're trying to take inspiration again from metabolic care. So what I'm showing you here, this is called an ambulatory glucose report. It's for individuals using a continuous glucose monitoring. This was based on I think international consensus group, and it's product agnostic. So it's not like your Abbott CGM is the only one that uses this. All products that offer continuous glucose monitoring have kind of aligned on this framework for how you present this way, and in a way, present the data in a way that's actionable for patients and providers. So what you're seeing here, the lower part is their daily glucose profiles over 2 weeks. The hyper and hypoglycemic events are highlighted to try to call out days of the week or times of the day when concerns arise. They kind of report this average profile in the middle and some summary statistics at the top to show how often you're in range. And I think it's really exciting, the work that went into this, because it's really informed the conversations between patients and providers on how they modify treatment plans or work towards behavior change to try to increase that time in range. And we've been exploring taking similar approaches. So here, this is just a mock-up of an ambulatory temperature profile. So here, these are temperature readings from an example user over 3 weeks. The 2 lines are temperature data from the left and right insole. Areas with concerning asymmetry are highlighted in red. Potentially, you summarize this over the average of some time window and provide some high-level analytics. So we're really excited to continue learning why these signals fluctuate throughout the day, and how we can help providers use this to inform what sort of interventions they're providing for patients. Another unique aspect of the system is that it is multimodal and multi-feedback. So what that means is We enable monitoring across multiple physiological domains, including plantar pressure, plantar temperature, and activity. And some other solutions in this space, they really focus on that remote temperature monitoring aspect, which has a very strong evidence base. But I'll show one case example that highlights the limitations of monitoring only a single warning indicator. This is an example case. This was from an observational study we did with Dr. Brock Leiden. He's a podiatrist in Ohio. This is a user that was enrolled in the ORPICS program. X-axis is 5 months across time. The top plot is showing abnormal pressures in the left foot, the middle abnormal pressures in the right foot, and the lower is showing left-right temperature asymmetries. The thing to take away here is that data in the red is bad. That's considered a data trend of concern. And the key data trend that likely stands out is those left lateral forefoot abnormal pressures. This was noticed by the remote patient monitoring nurse that was reviewing their ORPICS data, and the nurse escalated it to the patient's provider brought patient in, and they were developing a pre-ulcerative callus in that lesion, and they were able to provide proactive care at that point in time. But what's interesting is that if you were with a temperature monitoring solution alone, at this point in time, there were no temperature trends of concern. So there was no signs of inflammation that triggered a warning. And it's possible that if you would have looked into the future, that it could have been some time before a temperature trend of concern emerged, and that wound may have escalated to something more serious. So we've done quite a bit of work. Evan Minty is the medical director at ORPICS. He's also an internal medicine physician out of Foothills. He has a background in data science and statistics, but he's done quite a bit of work putting out guidelines on how this multimodal sensor-based remote monitoring supports monitoring throughout the DFU pathogenesis pathway and this multifactorial system, which I think is really exciting. The system is also multi-feedback. So what that means is there's 2 different feedback mechanisms that are supporting patients in this program. Patient-facing biofeedback and remote patient monitoring. So what each of those means, patient-facing biofeedback is that for users that are interested, they can use an app to get real-time behavior change notifications on their phone to offload their feet when there's abnormal pressures. And then for users who are not interested in that, all of our patients also get remote patient monitoring, where a nurse is checking in on their data at a regular cadence, 1 to 3 times a week. And calling the patient or provider if any concerns arise, so they can get in for assessment or support before things escalate. One other aspect we really focus on is how we can personalize care to the individual. Personalized medicine is certainly a very hot topic. And one area we've zoomed in on is for temperature monitoring. Those foundational research studies, they really focused on using a fixed temperature threshold for what's considered a concern. The risk is some users have asymmetric foot temperatures at baseline due to underlying comorbidities. So you can imagine your individual with peripheral arterial disease, for example, they may have impaired perfusion to one limb. So at baseline, their right foot may be much warmer and their left foot may be much cooler. So you risk that your foot ulcer monitoring protocols are going to constantly tell you you're developing a foot ulcer on your right foot, and you may miss ulcers developing on your left foot. And we, just to show an example, what we developed to support this was a baseline temperature asymmetry algorithm, which adjusts the thresholds to be personalized to the user. So this is a simulated data set that if you're a user that was asymmetric at baseline, you may be constantly generating these temperature warnings, these inflammation warnings. Doctors are super busy and they get really mad if you cry wolf and you send a patient in and there's no problem. So this is bad, they don't like this. So with our the baseline temperature asymmetry algorithm we developed, it personalizes the threshold to the user's temperature profile during their initial time in the program with the hope of reducing those false positive warnings. And similarly, if you deviate from that personalized baseline, we risk the false negative scenario as well. So, okay, so that's where we are today. At ORPICS, we're really focused on continuous monitoring, multimodal, multi-feedback, and personalized. Just for the last few minutes, I'll kind of look towards the future. This is always the fun part of the talk. Where are we going next? So primarily, I shared a lot of research on for DFUs, diabetic foot ulcers, how you can evaluate risk using temperature. And we know that is a really valuable and key signal. But foot risk is not one-dimensional, and we're excited about how we're expanding these lists, this list of signals and data inputs to move from a narrow view to a multi-system view. So just to recap what a typical remote temperature monitoring protocol would look like. A user with diabetes would measure the temperature on their feet. They would look when their left and right feet are asymmetric. Typically, you use a hard threshold rule. Is the asymmetry over a threshold? Yes or no, is there a hot spot? You proceed from there. But what we're really looking towards, rather than remote temperature monitoring, is remote patient pedal monitoring or remote patient plantar monitoring. So how you're building out this story by leveraging several inputs. So this may be your sensing technology inputs, but maybe you also infuse aspects of the patient's history that may bias their baseline risk. You can incorporate imaging technologies, photos, or other assessments of the feet. You extract the features that you know are relevant and related to foot wound risk. Use some annotated data to train your multivariate models, and then maybe rather than a binary classification, you output this risk, this continuum of risk factor of diabetic foot ulcer risk. And one other aspect that I think is really exciting is those traditional remote temperature monitoring protocols. The action in response to a hotspot was typically reduce your activity until the inflammation goes away. You can imagine telling someone with diabetes to be less active can be challenging sometimes, and it's sometimes in conflict with their other health goals. That's also very problematic if it's a false positive. If there wasn't actually a hotspot and you told them stop walking, that's extra bad. So we're also excited about how if there's ways you can kind of calibrate things to what the patient or provider's goals are and provide personalized recommendations of what the intervention or treatment plan is. And then moreover, this doesn't have to be a one-dimensional system, but rather these digital enabled solutions create this feedback loop where once you provide some intervention, you can actually use your sensing data and your sensing technology to evaluate if the intervention did what you thought it would do. So for example, if you want to provide them a new insole with a slightly different insole, offloading or modification, maybe you use the plantar pressure data to evaluate in real time, did it have the effect you hoped? So a lot of this is focused on diabetic foot ulcer prevention, but remote monitoring also has several other exciting applications that we're excited about: vascular care, frailty assessment, gait and fall risk, and I'll just highlight a few. So one is vascular care. Temperature monitoring has already been used as a proven tool to evaluate limb perfusion in individuals with peripheral arterial disease. What you're seeing here on the right, this is a angiography image. It's showing perfusion in the vessels, complemented by thermography of the foot, showing the vessels that are open and have blood flow going through them, or also the areas that are warm on your thermographic image. And there's a really close association between vascular disease and diabetes, so this is a really natural progression for us and something we're exploring. We have a case report on a single patient that's in review. Emily Bragg, who's the director of clinical affairs at Orpix, has been in collaboration with the healthcare team at Mimic Health. It's a vascular facility near Chicago. And this is a patient that has chronic vascular disease and occluded arteries in their left limb, and they periodically were receiving revascularization procedures to essentially unclogs the pipes, right? There's something clogging a pipe or not allowing blood flow to get through. You unclog it, perfusion to the limb is restored. And we've been excited to see how the temperature monitoring technology can allow you to continuously evaluate that limb perfusion. This is a group that needs no motivation for why mobility is so important, but 1 in 4 Americans over 45 face serious difficulty walking or climbing stairs, contributes to depression and dementia. It's also very expensive. It's estimated that $2,000 to $8,000 in annual medical costs could be saved by keeping patients walking. But why is this number so high? 1 in 4 is very high. What's going on? Why we can't keep patients more mobile? And one aspect of that may be our ability to evaluate a patient's mobility in an appropriate and realistic way. So a typical clinic or office-based gait assessment may look something like this. The patient's walking down a hallway or some open space in the lab. A researcher or clinician is watching them. It has some advantages. It's convenient. It's very time efficient. You have that clinical face-to-face interaction, but there are also limitations. It's often subjective. It's sometimes reliant on the physician or researcher bias. And we know that this is an observed setting. This may not be how people are actually moving during their daily life. We do lots of tasks and challenging movements throughout our daily life. And it's possible that this more diverse and challenging set of activities elicits subtle changes in our movement patterns that are more predictive of mobility decline. So with wearable sensing technologies, what we're really excited about is this lab to life mobility monitoring. So how do we transition from this office-based paradigm where you're kind of these episodic visits at some cadence of time and it's subjective and observed and controlled, and how do you transition to something that's digital enabled? You monitor someone's movement continuously. It's more realistic, so you're seeing their movement performance, not just their movement capacity in an observed setting. And it's also so exciting because it really opens up the opportunity for monitoring at scale. You're not just observing a select subset in your clinic that you're kind of worried about. You really have the opportunity to passively monitor a population at scale. So we have a unique opportunity with sensorized technologies like sensing insoles to evaluate gait balance and mobility during daily living. But as much as you love data, more data is not always better. You got to know what you want to do with it. So one example paradigm is that you have this intelligent monitoring and opportunistic capture. So that means if someone's wearing a sensory insole during their daily living, you intelligently monitor for when they're doing certain movements of interest, and then you capture the relevant mobility metrics during those distinct movements of interest, so you can track them longitudinally over time. We know that there's research here and across the world looking at what sort of gait biomarkers are most predictive of balance and stability and fall risk, but something worth noting is this is an approximation, but many of these metrics either require sensors at the level of the foot, or they may be more accurate once you have sensing technology at the level of the foot. There's so much great gait research using activity trackers or wristwatch-based technologies, but sensing at the foot does open up some possibilities. So just to recap, if you're kind of looking at an intra-step or gait monitoring application, the insole could be configured to monitor continuous pressure from that pressure sensing array. You can monitor temperature continuously. Temperature is a much slower moving signal, but you could monitor that continuously. And then the inertial measurement in the rear foot allows you to track the accelerations and angular velocities of the foot. So we worked quite a bit with Benno's team and tons of great researchers here in the HPL to start to develop some algorithms to extract these gait biomarkers, things like your spatiotemporal metrics by leveraging your IMU or your force to start to understand when your foot is on the ground or off the ground. Is there any asymmetries left to right? Things like leveraging the pressure sensors to look at the pressure distribution throughout the gait cycle. This has tons of applications in diabetes and a podiatry setting when you're looking at how the pressure is distributed across the foot. Are there any sort of foot deformities or gait abnormalities that are putting concerning pressures on the foot? We can use the IMU to look at foot kinematics. This allows us potentially through the swing phase of walking, look at metrics like foot clearance to help us understand your stability and fall risk. And I always like this last example. This is looking at your stability or postural sway, how you're moving as you're standing. So this is some data that the main group collected. This is a healthy individual. We're looking at the center of pressure estimation from the pressure sensor array in the medial lateral and anterior posterior direction. Your healthy individual, super stable, very small postural sway area. The study also had an individual with peripheral neuropathy. Your postural sway area is a little bigger. Parkinson's, your postural sway area is a little larger. So you can really imagine that if you're monitoring these sorts of signals continuously over time, you have the ability to monitor for improvements or decline in someone's movement ability or balance or stability. What would you do with all this data? Still figuring that out. Everything is really application specific. So you can kind of collect these metrics and report them relative to certain population thresholds or clinically relevant benchmarks. You can summarize them into your summary score of how good your walk or your gait is, but so much of this matters on what the specific application is and whether it's intended to be patient or provider facing. And one specific application we've zoomed in on with Dr. Sayibaya and Mahika master students is a sensor-driven frailty assessment. Frailty is an age-associated multi-dimensional disease that is an indicator of your functional status. So there's many clinical frailty scales. This is just one of the options, but you can see level 1, you're very frail. And then as you progress, it's an indicator of your reduced independent functionality. And why it could be valuable to monitor this proactively is that it's quite sensitive to treatment. If it's identified early, you can slow or even reverse where you are on the frailty scale. And we've also heard from our podiatry collaborators that frailty often informs treatment planning quite a bit. So I'll give you an option. If there's something wrong with your foot and you have a surgical and a non-surgical option, if you're someone who's quite frail, and if you're going to have surgery and then the doctor's going to put you in a boot, the likelihood that you're going to trip in your home and cause something more catastrophic is quite high. So you might be a candidate for the non-surgical option because your frailty status does not predispose you to having success with your post-op care. So we've been working with the team to explore the goal of how can continuous naturalistic mobility monitoring detect subtle changes in gait and activity that are correlated to clinical biomarkers of frailty and fall risk. So the team at the Heller City Lab is using the sensorized insoles as well as GPS to try to develop these predictive models of your frailty status. Okay, and then just to end on a slightly less data-focused note, the management of diabetic foot ulcers and any other chronic condition is certainly very focused on prevention, but there are limitations to being so zoomed in on prevention. And I'll share a quote from a study on remote temperature monitoring that I think about quite a bit. These authors reported that at-home skin temperature monitoring for ulcer prevention, it's considered a performance avoidance goal. Participants need to do something on a daily basis with the aim of not getting an outcome. You have to do something to not get the ulcer. And this is really a daily reminder of a participant's high foot ulcer risk. This continued risk awareness might stimulate preventative behaviors, but the fear associated with the outcome might also impact their quality of life. So truly effective care has to go beyond prevention and avoidance alone, but kind of zoom out to how you can provide these care models that are adaptive and motivational and personalized. So I'll share a few examples from one project. Again, another WeTrack work experience student, Mackenzie, from the biomedical engineering department. She explored how you could use context-aware biofeedback to provide more motivational behavior cues to the patient. So she investigated some of the pressure data from the sensorized insole. Here, the x-axis is 24 hours in a day, and the y-axis is steps. The green areas, when steps are accumulating, are times of the day when the user was more active. And then she's highlighted in yellow the abnormal pressures on the right foot, and in red the abnormal pressures on the left foot. So something that stands out is the red zones are more so happening when you're active, and the yellow zones are more so happening when you're inactive. So how could you use that context to provide something that's more motivational? So rather than a generic app notification, what if it was personalized to the context of that time? I noticed some abnormal left foot pressures when you were walking. Have you checked your shoe tightness today? Trying to cue them with what sort of behavior change is most related to that context. I noticed abnormal right foot pressures while you were sitting. Can you reflect on what sort of postures may have contributed to that? And then this last one, it's again that focus on fear and avoidance. There's always opportunities to kind of celebrate the wins along the way. This is very common in wearables and activity trackers, kind of celebrating something like your longest activity bout was 1 hour, great job. And one final aspect from this project that I was really excited about was Mackenzie was also exploring how our nursing team might be able to provide personalized guidance and encouragement and more adaptive care. So what she did is she did several interviews with our in-house remote patient monitoring nursing team to try to understand how the nurses and the patients are engaging with the data from the ORPICS program. And a key finding she had was that there's this diverse set of user profiles that shape how they engage. So you might have your more engaged user, someone that's really data and tech savvy. A nurse commented, this is the kind of person, they like getting those app-based alerts and so they can take action right away. You might have your more autonomous users, they don't like being told what to do. They're very busy. This nurse says I have a patient who doesn't like talking on the phone. They prefer everything over text because they're so busy. And then maybe you have these other, your less engaged users or your relationship-oriented users, those that really value the nurse, the remote monitor checking in with them. Nurse commented, I think they just want to know that someone's taking care of them and someone cares about them. So understanding these profiles and that they likely change over time, someone may not be an engaged user all the time, can really change how we provide that adaptive and personalized care. So thanks so much for having me today. I thought this was such a great opportunity. Just to recap, we talked about the past, some of the evidence of how learnings from leprosy informed our knowledge about diabetic foot wound development. I talked about the present today, how digitally enabled solutions like Orpix are enabling this continuous remote monitoring, and we'll look towards the future, towards some extended opportunities. So very excited for any questions, but if we don't get into anything, my email's here, and I really welcome any feedback.
The floor is open for questions.
Would these patients have to wear this pair of shoes with the pixel all the time, like in their house and outside, or might have more than one pair of shoes when they don't wear shoes?
So guidelines for high-risk individuals with diabetes, whether they're using a sensorized insole or just a regular diabetic orthotic, is to wear them for all weight-bearing hours. I've seen everything that happens when you're in your home. Someone stepped on a broken glass in their home and they didn't feel it and they didn't realize it until the next day, until their sock was bloody. So the guidelines are to be wearing protective footwear all waking hours. So some individuals do have a pair of house shoes and a pair of outdoor shoes to ensure that they're getting the maximum foot protection, again, whether it's a sensorized insole or a regular diabetic orthotic.
So like these more footwears with the others one.
Today, we only allow one insole to be paired. So we either guide them to wear the sensorized insole in whichever pair of shoes that they wear the most. And in the future, we are hoping to enable the multi-insole support so you can have your pair in your indoor and outdoor shoe.
I think about like the older population, so is it customizable for patients who have arthritis? Because you're gonna have change in gait with arthritis inflammation there. Is there a way of distinguishing the progression of inflammation from arthritis versus diabetes? Is it personalizable that way?
That's a good question. So with inflammation and temperature monitoring, we typically use whatever their status is at the time they enroll in our program as their baseline. But your health status changes. Your arthritis may become more significant, or whatever other health factors contribute to your inflammation may change over time. So right now we try to personalize it by looking at what your status is when you enroll in the program compared to the future. But we're trying to work towards something that's more of this rolling monitoring window, seeing when your trending changes. But kind of working towards identifying if it's due to an ulcer, or if it's due to Charcot, or it's due to arthritis, I think is something we need to do more work on, because I think that's a great suggestion.
I was just wondering, what's the care after someone is starting to develop an ulcer? Is it, medical interventions like we're going to do a procedure on you, or is it rest? Or I mean, I imagine it's both. But is there rehab involved, or that kind of anti-rest?
My understanding, as like many things, is it depends. Usually the first step is once an ulcer develops, you go into your podiatrist for debridement. So that means that they kind of cut away all that skin that's over top of the ulcer. They cut out that callus that's over the ulcer, so it's exposed and it's time to heal. I think based on the severity and location of the ulcer, sometimes things like an insole modification, where they cut out a little offload in the insole to reduce pressure on that part of the foot while it heals, is an option. Sometimes they're put in offloading boots, and those offloading boots vary, where it's like a removable offloading boot that you hope they wear it. And sometimes they're put in a permanent offloading boot, which fixes the ankle joint so that you can minimize the pressure on the plantar surface of the foot, and you remain in that offloading boot often for weeks until the ulcer heals.
I see. So I think I interpret most of that as just being rest.
Different ways of putting less pressure on the region, yeah.
So is there any such thing as exercise? So what I mean is, of course, for overall health, we always love people to exercise, but I don't know, the way you make your muscles stronger is you de-stress them. And then for this kind of condition, is that kind of off limits, or is there still some level of healthy stress that's good?
I'm hopeful that the space will move towards more active options for treatment once we have the tools to keep a close eye on patients to ensure we're not making things worse. So I think the guidance for people to be less active or do these sort of like archaic, put them in an offloading boot, is because that's something that we have total confidence that they're not putting pressure on their foot, that they're being low risk. I think if you had sort of tailored exercise where you could continue to monitor the region in some way and make sure your exercise program isn't making things worse, then that is, as you say, so much more in alignment with preserving their foot health and supporting their overall cardiovascular health as well. So I think a lot of it is probably based in fear that you're going to send the patient home for weeks and you want to be conservative, but if you have more monitoring visibility, perhaps those more active treatments will become more popular.
Well, I think that that sounds promising in the sense that, so I feel like if you go to an orthopod, a sprained ankle, broken arm or something, it's also like 6 weeks in a cast or in a sling or something. And I feel like that also is just super conservative. Because nowadays, you know, if you do an ACL surgery, that a lot of times they're moving the limb immediately, right? So that means that some degree of understanding movement is helpful, is built in. But then when you see your orthopod, like, got out of the hospital, and now it's still, no, just you're on crutches, and then, you know, we'll start rehab after 6 weeks. So I feel like this is a case where I sort of expect some kind of exercise, I don't know what it is, would be helpful.
Motion is lotion.
Okay, so a little bit peripheral to that. What about so nowadays people are monitoring all sorts of things. So they're monitoring their blood glucose, and then maybe they're also doing oxygenation. And so I'm wondering if, even if you're not interested in the feet, but let's say their primary care doctor is interested in monitoring all these things. So can you plug into all that stuff, and either they're interested in what you're reporting, or maybe you're interested in glucose and oxygenation and stuff like that?
I think that's totally the way of the future. So I think that's really valuable for two reasons. So these sort of integrated systems is one, how you capture the data, and one, how you store and handle your data management. So you can imagine something like that Orpix hub, whether it's the Orpix hub or some other device. Right now, it receives data from your Orpix insole, but what if there was a centralized hub that receives data from all of your continuous glucose monitoring, your CGM and your insoles and whatever wearable. So it's all coming to one centralized place. And then ideally, it also all goes to a centralized reporting platform or one that there's allowed to be some integration. So you can start to draw correlations between your metabolic care and your foot care if you like, or transition to focus on metabolic care when that's the highest priority, and then transition back to foot health when that's the highest priority. So I think that's such an exciting space, these sort of kind of smart, integrated, connected care systems. Yeah.
Well, not that I want you guys to make tons of money or anything, but I think it would be interesting to have everyone wear these. So, you know, especially maybe athletes, because they also are concerned with, it's a similar issue, which is basically every day. It's not an ulcer, but it's basically, am I overtrained, or, you know, what should I do? And so right now, I don't know what we do. We take maybe resting heart rate and maybe temperature, I don't know what else. And then, so it's a pretty crude measure of overtraining. And then there's a question of what is overtraining. So the cardiovascular system overtrained. So maybe you could do something else that's, you know, stressing something different. And so, you know, I guess everyone is eventually heading towards, we're just in a sense, everything in the body. But then I feel like maybe there's already stuff that you can get from these sensors that can be helpful to someone, I don't know, runners or something.
I think it's a really interesting thought experiment to think about who you outfit with sensing technologies. So the kind of a parallel example, so at Orpix right now, with the programs that are fundable, you're only eligible if you are at high risk of foot ulceration, which means you've already had an ulcer. So right now, our program is focused on preventing recurrent foot ulcers. But if you are monitoring in a wider population, ideally you prevent that first foot ulcer from only happening. You can probably guess why it's only the high risk people that are eligible. It's because they're the most expensive, right? So they're the biggest kind of slice of the pie for cost savings. But yes, I totally agree. If you kind of expanded, your opportunity for preventative care moves even more upstream, ideally, I think.
Okay, Matt and then Brent.
Thanks, Emily, that was great. Maybe just a bit of tangential questions relative to what we were just talking about, but with, I'm just thinking about the scenario right now in America for sure, where GLP-1s are huge. And, you know, I think in some cases people, because type 2 diabetes is a metabolic disease that in some cases can almost be attenuated or even reversed with good lifestyle changes, and obviously GLP-1s are a long way towards probably improving that. My question is somebody who has this propensity for this condition, if they were to come on, let's say they were to reverse their metabolic disease and sort of stabilize, does the diabetic foot condition remain because of the nerve damage, or do people tend to heal a little bit in terms of their nerve function, and eventually maybe if they manage better, they can actually avoid the problem? You got any thoughts you can say on that?
That's a really good question. I'm not the expert, so anyone chime in if they're smarter than me on this. But so I think some things are non-reversible. My understanding is diabetic neuropathy is non-reversible. So once you have that nerve damage, that will be a risk factor for the rest of your life. Your immunocompromise and your ability to heal ulcers is tied to your glycemic control. So part of the reason why foot ulcer is so concerning is because it's hard to heal. So you may still have that neuropathy, but you may have improved capacity to heal wounds as they form. So I think with that, kind of looking towards how this plays with the GLP-1 space, like I do think that's a great thought, that some of these risk factors related to foot disease probably are related and reversible. But I think the neuropathy piece will continue to be a struggle. But also if you have your better glycemic control early enough in your diabetic lifetime that you don't even get to that point of neuropathy, then you've avoided this altogether. So that's a really good thought.
Brent, and then we have a student question and an online question after.
Did you say patients are eligible to get the insoles if they've got amputations?
Yeah, so we have seen it all. It could be a partial foot amputation, like your big toe's been amputated because it had a poorly healed wound. It could be a transmetatarsal amputation, so all your toes have been amputated. Or we also have users that have an entire foot that's been amputated, so they have 1 foot remaining. And that makes it challenging for temperature monitoring because much of it is based off using your other limb as the control. So we do have some additional algorithms that look not only at the temperature between the left and right foot, but how a localized temperature compares to the regions around it to try to support individuals with amputations, but maybe you're going somewhere else with your amputation question.
Well, that's where I was going.
Yeah.
You present so many algorithms based on asymmetry.
Yeah.
And it would seem to me that if you were able to get it to work for that person with no foot, that would be probably the most robust algorithm that you could use, and you could move away from asymmetry sort of completely, right?
Yeah, and it's such a hard problem, but it's not a population that can be ignored, because once you've lost one limb, there's truly nothing worse than losing the other limb, right? So it's really a slice of the population that would so benefit from preventative care, and also they're just at such a high risk, right? Once you've had one limb amputated, your foot deformities and your gait abnormalities are all exacerbated. So but something we can always improve on. Yeah.
Okay, another question here?
I was curious about the intelligent monitoring. Like, how does that work? And also related, how do you develop the models?
Good question. It is in progress. You should help us. So the intelligent monitoring would be, so something like your, I have Aura Ring. The Aura Ring, the temperature sensing sucks during daily living because you like wash your hands, take a shower, like it's not really useful. So what it's monitoring is for when it wants to turn the temperature sensors on. So it monitors for when you're sleeping, and then it mostly only uses the temperature sensors when you're sleeping. So intelligent monitoring just means some things are passively monitoring all the time, and then you turn on or kind of increase the frequency of certain sensors when you know they're doing an activity that those signals are more robust. And then how do we develop the models? So much of it is like, this is why it's great to have university collaborations, is with any sort of wearable algorithm, the typical workflow, you develop your wearable sensor signals, you develop your gold standard measures in the labs, use your force plates and motion capture and all that, to try to develop algorithms that use your wearable sensor algorithms to get close enough to the gold standard that it's sufficient accuracy for the use case. So a lot of studies where you're collecting your wearable sensors synchronously with gold standard measures.
Online question.
Okay, Adam, go ahead.
Hi, Emily. This is Adam Bradshaw. Thanks for the presentation. I'm wondering, does a prescribed orthotic for individuals with diabetes or specifically peripheral neuropathy have kind of specific characteristics or features? And then does the Orpix insole include those features, or does the sensory tech interfere at all? And then second thing, on slide 56, I think you're missing a very important collaborator picture in the top right corner. So
We'll send out the updated deck and make your face really big on that one. Thanks for calling that out. Okay, so the first question was about specific features of diabetic orthotics, and they do have specific characteristics that in order for us to be reimbursable, so people can get paid by insurance or whoever for it, we do have to follow all those guidelines. So those characteristics relate to the types of foams used, the thickness of the foams, as well as what sort of modifications you allow. So this is half science, half art. There's some science about how you contour an insole and add posting and add different features to it. But we at Orpix or any other orthotics lab has orthotics technicians. They've spent decades working in manufacturing orthotics, and they know how to use the foot scan and the prescription from the provider to featureize the insole with any modifications that are required for the patient. And we don't always get it right, whether it's Orpix or just a non-sensorized diabetic orthotic. Sometimes people cycle through modifications to their orthotics over time to land on something that's appropriate for the user.
Right.
I will let one or two short questions be asked. One long or two short. You both can fight it out, Walter and Maria.
One or two.
Well, let's see what your first one is.
Very restrictive. So I'm not worried about developing an ulcer because presumably I have healthy feet. So I think feet are made to perfectly adapt to any pressure that it sees. And I can run a marathon and it doesn't really matter. It's just adapts. So therefore I'm asking myself, is it actually a matter of pressure? Or is it really a matter of the tissue that you have available? So how, are there any efforts in trying to characterize, the plantar surface of the foot to kind of get an idea of who might be at risk? Because I would assume, all of us in here presumably are not even worried about putting too much pressure on our feet.
I think that's a great question because your tissue damage, there's always two parts, right? There's your applied load and then your load tolerance, right? So a lot of what we talked about is like measuring your applied load, but I think what you're talking about is the load tolerance compromised in individuals with diabetes, I think 100%. So things like muscle wasting and very thin tissue or loss of subcutaneous fat in the foot all predispose them to injury. Do we currently infuse any of that information here? No. Should we? Absolutely. I think your load tolerance is not only different if you're a diabetic, but it's also different on different areas of the foot, right? So I think you're totally on the right track. There's opportunities to kind of adjust your priors, like adjust how biased you should be, how scared you should be about pressures at different regions of the foot or a different individual based on their kind of low tolerance, I guess is.
I'm gonna have two super short questions. The first one is, you talked about optimize installs for pressure distribution. How do you do that? Like, what would you call an optimal pressure distribution? Like, is it even distribution over the entire sole, or is it loading some of the areas that are normally good? What's optimal?
So we leave this up to the podiatrist, but I have learned there are two very distinct camps in podiatry where you can create a fully offloading orthotic or what they call a functional orthotic. So a fully offloading orthotic would be I take a 3D scan of the surface of your foot, I make the insole the exact negative of that with the hypothesis that that creates perfect uniform pressure across the foot. There are no areas where there's local high pressures. You've pushed out the pressure perfectly. It's a great way to make all the muscles in your feet waste away, right? Like you're just like holding up this structure and not making the foot do any work.
And you start loading areas that normally would never be loaded.
Exactly. You're forcing uniform loading where maybe it shouldn't be uniform loading. So there's this kind of other camp where it's more functional orthotic, where you think about that idea every time you offload something, you unload a different area of the foot. We assume our body weight doesn't change, that the pressure on your feet has to stay the same somehow. So there's this other camp of podiatrists as they do their design. Yes, they think about reducing like hot spots of pressure, but they also think that anytime you offload a region, you're onloading somewhere else. So what are your riskiest areas you want to offload? What are your low risk areas that might be okay to experience a little more pressure?
Another quick thing that you mentioned, you mentioned that, some people have natural differences between temperatures and so on. You want to be correct for that. And so you take baseline measurements. How do you decide what baseline is? Like, when do you do that? How do you do that?
We iterated on a lot of options, and we tried to investigate what a lot of other wearable technologies do. We're not the only ones, like all your Apple Watch and your Oura Ring, they all do these baseline measurements. And we wanted to land on something that was a long enough window of time that you were measuring a reasonable pattern of their typical physiology. You're not just picking up the spiky noise in their first few days. But we didn't want the baseline period to be so long that they were missing out on us delivering the value of the personal baseline. We iterated on the parameters. Where we landed, I think, was something on 2 weeks to 2 months is where we look at their baseline, because we felt that was a reasonable balance where foot physiology signals specifically, if you want to think about the noise and you want to get a reasonable sample of signals, that it was reasonable for our application. So
like for 2 weeks, continuously 24 hours a day, 2 weeks here.
Yeah, for as many hours a day that they're wearing it, that usually is like you're very adherent 8 to 10 hours and yeah.
Great, thanks.
Maria, we'll end with you.
Well, thanks for your talk. First of all, I really enjoyed it. I'm just curious if you think, based off onto pressure data and like where diabetic individuals experience those hot spots or those ulcers, if it would be possible or beneficial to prescribe activities that wouldn't aggravate those specific areas of the foot.
I love that idea so much. We should integrate that. Yeah, like we've heard of users, like I think a very typical, if you're worried about your patient walking, you put them on the recumbent bike, like the bike where you're sitting and you still get exercise, but it's a little less pressure on your feet. But I think that's such an awesome way to kind of personalize it to the user if there's certain regions of the foot or one of their feet that can kind of, sounds like you're saying, keep them active, but still protect the parts you care about. So I think it's a great idea.
Awesome. Well, Emily's email is right on the screen there. So for any other burning questions, I will let you reach out to her directly, but let's thank her for her talk. Thanks for talking.